We got Instagram going, we got Facebook going. Awesome. So welcome to PT on Ice Daily Show. My name is Dr. Jordan Berry, lead faculty for cervical management and lumbar management in our spine division. Today we are discussing on Clinical Tuesday, neck-related arm pain, or is it? In other words, are there commonly missed clinical patterns that we see of something that could cause upper extremity symptoms, right, that might not be coming from the neck? Before we dive into that, I just want to mention a few of our courses coming up. So in January, we've got pretty much all of our online courses starting. Basically every fitness athlete course, we've got Essential Foundations, Advanced Concepts, and Pregnancy and Postpartum. From our Modern Management of the Older Adult division, we have Essentials and Advanced Concepts, and then Persistent Pain Comprehensive Management as well. A few other courses as well, but all of those are starting in January. In terms of live courses, January 16th and 17th, we've got Cervical Spine Management in Richmond, Virginia. And then January 30th and 31st in Bismarck, North Dakota, we have Lumbar Spine Management. All right, so let's dive in. Again, neck-related arm symptoms. Are they generated from the cervical spine, or is there some sort of clinical pattern that we might be missing in the clinic? Okay? In other words, if a patient comes in and they have symptoms, right, somewhere in the upper arm. So I'll demonstrate on Kelsey here. Kelsey, hop up for just a second. So that patient that comes in that maybe has symptoms, kind of vague symptoms on the posterior lateral shoulder here, right? Or maybe a bit more local, anterior in the shoulder, or some paresthesia coming down the arm, maybe into the fingers or the hand. Okay? Think about that patient. So things that you might hear from the subjective is repetitive overhead movements in the history. So maybe they do a lot of pressing, right? Like barbell overhead press or things like that, or maybe a lot of vertical pulling, like toes to bar, kipping pull-ups, things like that. Also, from a complaint standpoint, you might hear that patient mention something about like a dead arm feeling or a heaviness in the arm when they're performing those overhead movements. Okay, how can we actually tease that out in the clinic to figure out if it's coming from the neck or if it's coming from somewhere else, right? So maybe we get into the objective exam because you can appreciate the things that I just mentioned do sound like it could be coming from the neck, right? Like a cervical radiculopathy or a neurodynamic issue. Because when that patient gets in this overhead position, right, that is what brings on the familiar symptoms. But then maybe we get into the objective exam, we go through, we have a look at the cervical spine, take a look at active range of motion, overpressure, retraction, right? We do our segmental exam, and nothing really shows up in the cervical spine. Where else should we be looking? Or maybe you originally treated the cervical spine and that has cleared up, but the symptoms have not resolved. Or maybe that patient has a lingering ULTT where it seems like neurodynamics are involved, but you've treated out the cervical spine and you've treated the nerve bed with sliders and gliders and things like that, but that ULTT is not resolving. What other regions should we be looking at that might be the primary symptom generator of these distal upper extremity symptoms? Okay, so at Onward Charlotte, I will say very, very commonly, the two most commonly missed areas that cause these upper extremity symptoms are posterior rotator cuff referral and an upper rib dysfunction. Okay, in other words, right here, somewhere on the backside of the shoulder blade, that posterior rotator cuff, if it gets irritated, can refer symptoms down the arm or coming a little bit medial, right in this area, the upper ribs here. If there's a dysfunction there, that can also generate distal upper extremity symptoms. Okay, so how do we tease that out in the clinic? Kelsey, hop down on the table. So three things. The first is what we're going to look at is strength testing. Okay, I like to test the rotator cuff, the external rotators, in a few different positions. And those positions change based on the irritability. So I like to start with the arm at the side and then bring the arm up into various positions of external rotation. So I will typically start with the arm by the side, stabilizing on the shoulder, and having Kelsey press into my hand here, okay? And this is a max strength test, holding for about 3 to 5 seconds to see if that reproduces any of our familiar symptoms, right, in the shoulder or in the distal upper extremity. I'll work my way out, right? So now I'm at a 45-degree angle, pressing here, then bringing the arm out into 90 degrees of abduction and checking external rotation strength. And then even bringing the arm in with some horizontal adduction, right? And also checking external rotation. Again, this is a maximal strength test, holding that contraction for 3 to 5 seconds to see if any of those positions of variable stress to the rotator cuff bring on those familiar symptoms. Okay, the next is palpation. So don't blow through your palpation. I think that can have some really, really important value in the clinic. So Kelsey, go ahead and flip to your stomach. So I know I'm flipping shoulders, but just for demonstration purposes, don't blow through the palpation. So when I'm coming, when the patient's in prone and I'm coming in here to check for any referral from the rotator cuff, I am coming all along that shoulder blade. So coming in along the medial border, coming right at the inferior angle, working my way out laterally, cross-frictioning and compressing all along the backside of the shoulder blade. Very often you are going to hit one of those spots where the patient says, whatever you are on, that is sending the symptoms down my arm, and then boom, you got it. Okay, so don't blow through palpation. Take your time with it. Be diligent. The last key is your segmental exam, right? So I said if we worked all the way through the cervical and upper thoracic spine and nothing really showed up, make sure that when you're in the clinic, you come a bit laterally onto the angle of the ribs and you work through and give a really hard PA to those areas to see if that might reproduce their symptoms. Okay, so again, if I'm going through my segmental exam and not really finding what I'm looking for, come off of the spinous process laterally, in between the spinous process and the medial scapular border onto the angle of the ribs. Give a really nice PA there and see if that reproduces any of the patient's familiar symptoms. If the symptom generator of those upper extremity symptoms is the posterior rotator cuff, you are going to pick that up with good palpation and that maximal strength testing in one of our positions, testing external rotation. If it's the ribs, you're typically going to pick that up on the segmental exam, where you come off of the spinous process laterally onto the angle of the ribs. Okay, treatment-wise, what do we see that's most effective for these areas? Kelsey, you can go ahead and hop up. So for upper rib dysfunction, I find that an upper rib thrust manipulation is really, really helpful for that area. We cover that in detail in our cervical spine management course. And then for posterior rotator cuff referral, I'm typically doing some sort of soft tissue work. My bias is dry needling. I think that that's really effective for that area. But if that's not available in your state or you don't have the education for it, right, you could also do like a pin and stretch or some decompression work with cups, but really anything to get that soft tissue on the backside of the rotator cuff moving. And then to follow that, you need a way for your patient to go home and reproduce what you're doing, right? To follow that with a way for the patient to mobilize that tissue as well. So Kelsey, go ahead and hop up, turn this way. So I love using a lacrosse ball for this. I keep it really simple. So if the upper ribs were an issue, I would have Kelsey place that lacrosse ball right here, just medial to the medial scapular border, right on the angle of the rib. Have her lie supine and just work that arm back overhead with the lacrosse ball right in this position, getting into the ribs. On the other hand, right, if it was the posterior rotator cuff, we could do basically the same technique, only slide that lacrosse ball a bit laterally onto the posterior rotator cuff on the backside of the shoulder blade. Again, same technique, lying on your back supine and working that arm overhead. Thanks, Kels. So just to review, if you're in the clinic and you have a patient with some distal upper extremity symptoms, right, that you've gone through and you've tested the cervical spine, nothing's really showed up, or maybe they have that lingering ULTT that's not getting cleared up with work to the cervical spine or treatment to the nerve bed like sliders and gliders and things like that. Two key areas that you've got to look at is the posterior rotator cuff and the upper ribs. Those are our two most common areas that we see missed as a cause of upper extremity symptoms. In the physical exam, make sure that you test strength testing, okay, external rotation in multiple positions, good palpation to the area, and testing on your segmental exam coming laterally and checking the ribs. If it is the rib, get up in that area and crack it. If it is the posterior rotator cuff, do some sort of soft tissue work to clean that up. Okay, awesome. I'd love to hear any thoughts, comments about that. If anyone is seeing that in the clinic, leave any comments or questions that you have on Facebook or Instagram, and we'll have a conversation about it. Awesome. Thanks, everyone.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.